We have over 100 people already in the room and up to 500 registered. So it's great to see so much interest in today's webinar. So we'll now begin. I'll just start sharing, screen. So thank you very much, everyone, for attending today. It's World Sarcopenia Day this Friday, that's the 4th of July, and we're really excited to be doing this joint webinar with the Australian and New Zealand Society for Sarcopenia and Frailty Research, and also the Sri Ramachandra Institute in India. And the theme of today's webinar is practical and novel approaches to screening and identification of poor muscle health and sarcopenia in primary care. My name is Jennifer Jones, and I am a physiotherapist and a lecturer at the University of Melbourne in Australia, and for the Australian New Zealand Society for Sarcopenia and Frailty Research. I'm the committee chair of our Early and Mid-Career Researchers and Clinicians Committee. I'm also the president-elect of the Society. A little bit about our committee. We are a team of early and mid-career researchers and clinicians. We have a committee of 4 presently, but we've just had a call for expressions of interest to join the committee, and we'll be really excited to grow our numbers. So working with a great team with Elsa Dent, Anuha Grandam and Ju from in Victoria and Australia and across Queensland, so all across Australia. And our mission is to promote, support and engage with as many early and mid-career researchers and clinicians as possible to shape the future generation of sarcopenia and frailty research. In terms of some housekeeping for today, we have our program shown here on the slide. I will next be handing to Anthony, our president of the Australian and New Zealand Society for Sarcopenia and Frailty Research. We will then have 3 speakers who have seen advertised, so Ben Kirk, Sabaya Kanthanan and Ross Clark, and we'll end with closing remarks from Krista Light from the Sri Ramachandra Institute in India. In terms of some housekeeping, we will have time for question and answers, and that you can post them into the question and answer functions on in Zoom, and we will moderate those at the end of the webinar. So feel free to let those questions trickle throughout the presentations, and we will then work to moderate those questions at the end, so after Krista Light has spoken. I can see someone has raised their hand. I might just check if there's any issues with the tech, otherwise maybe post in the chat and I'll respond as quickly as I can. I'll now hand to Anthony as the Australian New Zealand Society for Frailty and Sarcopenia Research President for the opening address.
You can feel free to move to the next slide, please, Jen.
Oops.
Great. Thanks so much, Jen. Firstly, welcome to everyone online today. I would also just like to extend my sincere thanks to you, Jen, and the EMCR committee, as well as our colleagues in India at the Sri Ramachandra Research Institute for your collaborative efforts in putting this wonderful webinar together to promote World Sarcopenia Day. So I'm really looking forward to this event. You know, we've got 3 high quality and internationally recognized speakers to discuss the topic of practical and novel approaches to screening and identification of sarcopenia, which is so very important for a number of reasons, as we're still moving towards a global and internationally recognized definition of sarcopenia, as well as acknowledging the many barriers which healthcare providers are challenged with when it comes to screening and identifying sarcopenia across the various different healthcare settings. And this may include the potential or the need for innovative and easy to use technologies to facilitate this, which we'll find out a little bit more about later in this webinar. Next slide, please, Jen. So just before we do get started officially, I'd just like to remind everyone about membership of the ANZ SSFR. So we're the peak body specialising in the study of sarcopenia and frailty in both Australia and New Zealand. And our society really aims to promote research excellence and the translation of this research so it can ultimately be used by healthcare practitioners. But in order to continue to promote awareness and ongoing research into sarcopenia, there needs to be a strong movement, and we need to have a presence as a society. And I think membership is key to this. And look, there are a number of benefits on offer when becoming a member of the ANZ SSFR, and these are listed on the slide here, ranging from education and professional development opportunities, networking, and so forth. And just lastly, to promote World Sarcopenia Day, we're offering discounted memberships. So if you're a new member and you purchased before the end of this month, so the 31st of July, and this also includes a discount for our renewing members and our existing members as well. We're also offering free membership for early and mid-career researchers. And all of this information is available on our website. So please take the opportunity to have a look at this, sign up today, and become a member. So thanks, everyone. Enjoy the afternoon of wonderful, innovative topics and presentations. I'll hand over to you now, Jen. I think you're going to introduce our first speaker.
That's right. Thank you very much, Anthony. So it's my pleasure to introduce a colleague and a friend, Dr. Ben Kirk, who will speak to the really pioneering work in the definition of sarcopenia. So what better place to start for our webinar? And Ben is a research fellow, senior research fellow at the University of Melbourne, and also a clinical researcher at Western Health in Australia. So Ben, I will hand over to you.
I think someone else has to stop. No, we're good. Just a second. You should be seeing my screen now, Jennifer. Is that correct?
Yes, it looks great. Thank you.
Excellent. Well, thank you for that introduction, and thank you to the societies, both societies, for the opportunity to present today on behalf of the Global Leadership Initiative on Sarcopenia. It's fantastic to be here and see a good turnout so far of attendees on a special day on an under-recognized condition. I think that we can all agree with. Now, I'd like to set the scene for sarcopenia by describing the importance, or reminding you of the importance of muscle health. Now, of course, we know over the past 30 years, especially through epidemiological evidence, how important muscle is for structural functions in the body, an older person for maintaining their balance and posture. And we know that muscle atrophy, particularly of our glute muscles, is a very strong predictor of falls and fractures, and causing hip fractures, which are detrimental and very costly. So we know that from a structural point of view, the importance of muscle. And thanks to, mostly through animal models over the past 10, 15 years, lots of translational work have been done, and we now know the metabolic functions of muscle as well. So if you have a healthy muscle and you contract the muscle fibers, they spit out myokines, and they can go to the bone and they can promote bone healing, for instance, after a fracture. Muscle myokines can also travel to the heart and help the heart remodel, and so on. And on the bottom right-hand side here, recent studies, Mendelian randomization studies, have shown us that genetic markers of loss of lean mass or loss of grip strength actually increase the risk for a whole host of different cardiometabolic diseases all the way from type 2 diabetes down to coronary heart disease. So what I'm trying to remind you here is the importance of muscle health, both from a structural point of view and from a metabolic standpoint as well. Now, Dr. Erwin Rosenberg, back in 1988, first described sarcopenia as age-related loss of muscle mass. I hear stories of when he was in the General Hospital in Boston, he used to describe sarcopenia as older persons who looked like they were losing muscle. So he was the pioneer of this condition. And over the past about 30 years, we've seen a number of different groups introduce sarcopenia definitions, and they largely have been region specific. So of course, we've had a definition in North America, we've had a definition in Europe and in Asia as well, and of course in Australia and New Zealand. And probably the most cited or the most well-recognized definition since 1988 has been that by Alfonso Cruz-Gentov and the European Working Group. And in 2019, they described sarcopenia as a progressive skeletal muscle disorder characterized by low muscle mass, strength, or physical performance. Now, of course, there's positives and negatives to having different sarcopenia definitions globally. I think the positives of this are that over the past 30 years, the emergence of these different definitions have allowed us researchers to look at prevalence, incidence estimates, health outcomes related to these definitions. So it's grown the importance of sarcopenia as a muscle disease itself. But of course, they've led to some problems. We've got no unified global definition of sarcopenia for research and clinical practice. Now, what has this led to? Well, number one, from a research standpoint, we don't know the true global incidence or prevalence of sarcopenia worldwide. From a clinical standpoint, it's led to confusion among clinicians regarding what tools do you use to measure muscle mass per se, what are those cut points, or which definition should you use if you have two definitions, let's say, in North America. Other problems include no official International Classification of Disease Code, ICD-10, by the World Health Organization. There are modified codes in the United States and Australia, but there's no official recognized code by the WHO. And also the FDA hasn't recognized sarcopenia as a disease nor a treatable disease either. And because the FDA hasn't recognized this, there's no regulatory pathway for drug companies for financial gain, I suppose. If they do create a drug, there's no pathway for them to make revenue. So I think this has hampered drug development process as well at the same time. So enter the Global Leadership Initiative in Sarcopenia, and this is to accommodate all these problems that I've shown you on the previous slide. And the main aim is to create a unified global definition of sarcopenia for research and clinical practice. Now, how the GLIS Steering Committee came about, as you can see on the left-hand side of the screen, back in 2015, Alfonso Cruz-Gentov, the president of the European Society, met with a number of leaders worldwide that were part of different sarcopenia societies globally, and they discussed about making a global definition, how they would go about it. And they agreed that an objective and a transparent Delphi process would be the best way to do that. So what they did was they got together a steering committee of members from each Continental Sarcopenia Society. As you can see, there was a 21 steering committee members invited on, and from that, the Global Leadership Initiative in Sarcopenia grew. So like I mentioned, there's representatives on the steering committee from Oceania, Australia, New Zealand, from Asia, from Europe, and from North America as well. And over time, over about 2 years, a number of musculoskeletal societies and sarcopenia societies, as shown here, were contacted and asked if an objective and a transparent definition was produced, would they endorse the definition? And thankfully, those societies agreed they would. And the World Health Organization was contacted as well, and they also outlined that they would be happy to endorse an initiative if it was transparent, if it was objective, and it was a unified definition worldwide. So that's how the Global Leadership Initiative in Sarcopenia came about. And as you can see stated in the text at the bottom here, it's endorsed by all sarcopenia societies worldwide, all leading musculoskeletal organizations ranging from the International Osteoporosis Federation to clinical nutrition groups as well out of Europe, endorsed by the WHO. And currently we have over 200 members from 29 countries that are part of GLIS. So this was the methodology used in the Delphi survey to establish the global conceptual definition. So the definition was put together, or rather the survey was put together to define experts' agreements on 3 particular aspects. So number 1, what should the conceptual definition of sarcopenia include in terms of general aspects? Should it be a disease, or should respondents think it's a disease, a disorder, or a syndrome? What are the key components that should become part of the conceptual definition in terms of muscle mass, muscle strength, and muscle function? And what are the clinically relevant outcomes of sarcopenia, things like falls, fractures, and hospitalizations? So the steering committee developed a set of statements based on expertise, and the surveys were sent to the full committee comprising of experts from all these different international societies and working groups. We used a standard Delphi method, 11-point Likert scale ranging from 0, strongly disagree, up to 10, strongly agree, based on survey respondents. And statements were classified based on these pre-specified thresholds. So statements with low agreement, so below 70%, if they had moderate agreement between 70 to 80%, and strong agreement above 80%. Statements with low agreement were rejected in the red, strong agreement above 80% were accepted, and statements with moderate agreement were reintroduced until agreement was found for those statements. Agreement or rejection, rather, after the second round. Now, to accommodate the survey in the GLIS, we also published a glossary of terms, so essentially a dictionary of terms used in sarcopenia. And we did this because there would be different interpretations of different statements in the survey. So for instance, if you look at muscle density, different people might interpret that as different, define it in different ways rather. So it was important for us to define that first through a glossary. And then this glossary was given to all respondents or outlined in the survey, so then they could interpret different terms correctly and answer the survey. Now, this is the overall participant demographics and characteristics of the people that completed the GLIS survey. There was 107 participants across 7 continents, 29 countries, who completed both rounds 1 and rounds 2 of the Delphi survey. We had reasonable representation rather from different continents. So you see 40% were from Europe, 22% from Asia, and 19% from North America, ranging all the way down to 4% from South America, and lower numbers from Africa and Antarctica and New Zealand. And regarding what those primary jobs were of those respondents, around about 71% were academic professionals working in university research and education, 22% were health professionals working in allied health positions, and 5% reported as mixed, so academic and industry professionals. Now here we have the summary of the accepted statements in a graphic. I decided to give you a graphic instead of all the 21 statements and rejected statements because it's easier to follow. If you focus on the left-hand side here, considering the general aspects of sarcopenia, these were the statements that were accepted above 80%. So GLIS respondents agreed that sarcopenia is a disease of skeletal muscle. It increases with age. It's potentially reversible. that the definition should not depend on your age, setting of care, or clinical condition, and that the definition should be the same for clinical practice and research. And regarding the important components of sarcopenia and what they should involve, the respondents agreed that sarcopenia should be defined by low muscle mass, muscle strength, and muscle-specific strength. So that's the amount of strength you have relative to your muscle size. Now, when we consider the health outcomes of sarcopenia, respondents agreed that impaired physical performance was an important outcome. Limitations performing walking, transferring from a chair or bed was also another important health outcome, and that sarcopenia increases the risk of falls, fractures, hospitalizations, and admissions to aged care facilities. And sarcopenia impacted your inability to perform activities of daily living, both instrumental and basic. And one of the health outcomes of sarcopenia is a lower quality of life and increased risk of mortality. So this is the summary of the accepted statements overall, considering general aspects, the key components, and the health outcomes of the condition. So what are the next steps? Well, we are now developing an operational definition, and this is underpinned by the conceptual definition that I've just shown you. And what the committee has decided to do is, in order to reach an operational definition, there will be 3 different working groups focusing on key components of sarcopenia that were agreed on the conceptual definition, including muscle mass, muscle strength, and health outcomes of sarcopenia. Now, these working groups will collaborate to agree on the operational definition, and the muscle mass working group is utilizing another Delphi survey amongst the GLIS respondents to identify cut points, to identify what is the best measure that is both feasible and accurate. And the muscle strength group is doing the same, and the health outcomes group as well, which I wish the paper has actually been published and they've reached agreement, and I will show you that in a second. And the idea is that once we have the global operational definition of sarcopenia, this will be endorsed by the WHO and integrated into the Dictionary of Medical Conditions, essentially the ICD-10, and this will facilitate definition and diagnosis worldwide. Now, this is the health outcomes recommendation by GLIS. It was published recently by Boudart and colleagues. And first of all, they looked at summarizing the evidence based on preferred tools, cutoff points, and minimal clinically important differences for health outcomes of sarcopenia. And they did this through a literature review. And what you have here is a heat map of the summary of strength of evidence for different sarcopenia outcomes. So the working group looked at meta-analysis at the bottom here. They looked at longitudinal studies and cross-sectional studies. And this is the heat map. So in the dark blue is the strong evidence. And they found that there was strong evidence that sarcopenia reduced quality of life, increased falls and fractures, hospitalizations, and at the bottom, increased risk of mortality. So originally what the GLIS conceptual definition agreed on, lots of the different health outcomes, is also supported here by the strength of evidence. But most importantly, the health outcomes group have defined tools and cut points to identify the health outcomes that were agreed upon in GLIS. So I'll just show you a few examples here. So impaired physical performance was an outcome agreed in the conceptual definition, and the health outcome working group have agreed that 4 to 10 meter usual gait speed, there's strong evidence to recommend that, with different cutoffs based on 0.6 meters per second, ranging up to 1 meters per second. And that depends on the population you're looking at, and also what is the minimally clinically important difference is 0.1 meters per second. There is high level of evidence to agree upon that. but of course, other outcomes as well that were agreed upon by the global conceptual definition, disability and performance ADLs, or IADLs, and which quality of life instrument should be recommended and suggested, and different cutoff points. They have all been established in the paper amongst the working group. So what is the summary and the next steps for this conceptual definition? Well, like I mentioned, the global conceptual definition will underpin the operational definition, which is now underway via Delphi consensus. So please, if you have received an email from GLIS, don't forget to complete that, and remember as well that all GLIS members who complete both rounds of the survey will be acknowledged as a co-author in the final paper, like what was done in the previous conceptual definition. So the operational definition is underway. Like I've shown you, the health outcomes paper has been completed and those recommendations are finalized. In terms of muscle mass and muscle strength working groups, both of those are currently underway as well. They haven't been completed yet. The muscle mass group Delphi survey is currently underway, and the muscle strength group are currently underway to establish the criteria for diagnosing muscle strength, what device and what cut points to use. So in collaboration, GLIS has signified a critical step forward towards advancing our understanding and management of sarcopenia on a global scale. And I should also mention as well that the idea with GLIS criteria is that it will evolve over time. So although we've reached a GLIS definition and the conceptual definition, operational perhaps at the end of this year, in another 5 years' time with GLIS and with the members, and as new evidence comes, that GLIS conceptual definition and operational definition will evolve, and there'll be opportunity for it to evolve. And that will always be guided by an evidence-based objective approach in terms of Delphi surveys or Delphi suggestions. So what are the future clinical priorities? Well, once we've established the operational definition, hopefully that's going to integrate it into the WHO and the ICD-10, the International Classification of Diseases. And from there, primary care pathways can be developed. And I believe as well, the FDA have acknowledged that they do acknowledge sarcopenia as a condition, and they do acknowledge the initiative of researchers worldwide and clinicians to promote sarcopenia, understand and treat this condition. And they've acknowledged that, or they've suggested that if a global unified definition is achieved, then they will consider about introducing it into the FDA or having it as an endpoint. And of course, future research priorities can be guided by this GLIS criteria. So in terms of what are the causes, the genetic, molecular, and cellular mechanisms that underpin muscle atrophy and the GLIS definition, and then going back to different care pathways and different pharmaceutical interventions and non-pharmacological, we need to find out what is the optimal exercise program that can prevent and treat sarcopenia and improve pharmacological drug development as well for this condition. I'm an exercise physiologist and I definitely have an exercise lifestyle approach, but I understand as well that there must be a pyramid of options, that not all older people with sarcopenia will exercise or can exercise. So there has to be other options as well. So different non-pharmacological and pharmacological approaches are still needed as well, very much needed in the field of sarcopenia. And this is the paper that was published in Age and Aging that signifies the global conceptual definition. Altogether, there's 107 authors that were members of GLIS at that time that completed this definition. So it was very much a unified collaborative effort from researchers, clinicians, industry people, all across different medical specialities and from different allied health professionals worldwide. And it has gained some recognition. I believe it has over about 230 publications since it was since the paper was published. And I've looked at where those publications have gone, and they are across a whole wide range of medical specialities. And that kind of just signifies the importance of sarcopenia across different medical specialities, and it is acknowledged as a very important condition. And we also have lots of evidence from that, like I showed you on the first slide, of why muscle atrophy is so important across health and disease. So I'd just like to finish by thanking everybody involved in GLIS, all the sarcopenia societies, the musculoskeletal organizations, and everybody that performs research on sarcopenia, and clinicians and allied health professionals who daily are trying to find ways to integrate and identify sarcopenia and manage it as best we can. So once again, I'd just like to thank everybody involved in GLIS, and thank the societies today for the opportunity to present.
Thank you very much, Ben, for your excellent presentation. Once again, we will have time for questions at the end of the webinar, so please do feel free to put any questions into the Q&A function. But it's my pleasure now to hand over to Geeta Haripriya to introduce our next speaker. So I'll just bring that up.
It takes immense pleasure to introduce the second speaker of the day, Dr. K. Subbaiah. Dr. K. Subbaiah is an associate professor and head of the Department of Musculoskeletal Physiotherapy, and he has more than 25 years of experience. He has completed his post-graduation in the specialty of musculoskeletal sciences and has great interest in the field of manual therapy, hand rehabilitation, and geriatric care. He has been actively involved in organizing many screening camps pertaining particularly to sarcopenia, conducted at the Department of Orthopedics at Sri Ramchandra Institute of Higher Education and Research. He has also conducted outreach programs and screening programs for the employees of the Sri Ramchandra Institute of Higher Education and Research, and also for the community on educating the community about sarcopenia. Today, Dr. Subbaiah will share his insights on the topic, Strength at the Frontline, Practical Approaches to Sarcopenia Screening in Primary Healthcare. We are excited to learn from your expertise and experience, sir. Over to you, sir.
Okay. Hi, everyone. Thank you for the introduction, Mrs. Geeta. So I will share the screen. Hope my screen is visible. So I welcome all the attendees on behalf of Department of Musculoskeletal Physiotherapy, Sri Ramchandra Faculty of Physiotherapy. So my topic is about screening for sarcopenia in the primary care, putting strength at the front line. So what you can expect in my talk. So we'll be addressing about the clinical significance of sarcopenia, and we have high time you have to recognize the barriers was what we face in the primary care towards screening, and how to recognize the early signs to suspect the probable sarcopenic individuals. And I'll be discussing about the available suggested screening tool to screen for people at high risk of sarcopenia, and structured approach for the screening, and to stratify individuals who are at high risk. So already Dr. Ben has detailed on the definition, so I will not go in much deep. So sarcopenia is a composite condition that encompasses both the quantitative and qualitative aspects of muscle performance. So muscle mass, strength, and physical performance were the parameters usually relied upon to screen and to diagnose sarcopenia. And nowadays they recommend to rely upon more of physical performance measure for diagnosis, and to measure the severity of sarcopenia. And for many of them, they have provided cutoff points. Still, many needs validation. So I'm basically a physiotherapist. So we do a lot of work regarding evaluation and promoting various therapeutic strategies in improving skeletal muscle performance among individuals of various age group. And sarcopenia specifically addressing special category of age group was more than 65. And it's high time need that we physios should be aware of such condition, and a lot of work need to be done, as we all should try to improve the functional ability of the special group so that automatically the quality of life will improve. Okay. Why early detection of sarcopenia in primary care is utmost important? So sarcopenia is an underdiagnosed condition in daily practice because of various reasons. And few to quote, lack of awareness among healthcare provider and the patient themselves. So many reasons. So on the special group, category of group whom we are going to address. So sometimes if you ask relevant questions regarding sarcopenia, so that itself may sound irrelevant. So the first challenge is we have to make the patient or whomever is accompanying the patient, the caregivers or the family members, we have to provide awareness to them about sarcopenia and about its ill effects and how it may progress and how it could impact their functional independence, ultimately affecting the quality of life. And as rightly pointed out, sarcopenia is a reversible condition, and reduction of sarcopenia at a very early stage is very important, because once the individual enters the vicious cycle of disability, then the related outcome after intervention, it will not be as good as intervention at the very early phase. So recognizing sarcopenia in primary care may improve the optimal care plan of an elderly person. And in an Indian context, the prevalence of sarcopenia ranges about 28%, and primary sarcopenia has a prevalence of 39.2%. So sarcopenia is a existing condition, and it's very important to diagnose or screen the sarcopenia at the primary care. So what is the common barriers commonly encountered in the primary care for screening? One is, I would listed these things in an Indian context. Few of them are applicable even for other parts of the world. So high cost and limited availability of the diagnostic tools. Even many centers lack hand anemometers. So now many agencies are recommending grip strength evaluation for quick screening. So that is one barrier. Then time constraints. That is not the priority for clinician or even the priority for the patient themselves. So patient have their own priorities, their own health needs. So in addition to it, without ignoring them, we have to take this task side by side. Unlimited training and awareness on both the sides. And in Indian context, the ethnic differences in body composition. So generally Indians have low lean muscle mass, higher fat percentage. So generally Indian dietary pattern has less protein intake, more of cereals. So adapting the cutoff scores, which is already, even though the Asian and South Asian groups have recommendation that is adaptable. So still the cutoff score or adapting it for Indian population is a challenge. And the variation in urban and rural settings. So the lifestyle, nutritional aspect, malnutrition, okay, the amount of physical activity they do, and awareness about health promotion or being active or quality of life issues, all may vary from urban to rural settings. So these were few barriers commonly we encounter in primary care in screening or taking sarcopenia further forward. So what are the emerging sarcopenic approaches or tools we have? So here's a huge list. So the first SARC-F questionnaire helps us to screen individuals for the risk of having sarcopenia. So it is a questionnaire. We'll deal with it in detailed way in the next slide. So maximum point is 10. So if the score is 4 or more, then the individual can be categorized under probable sarcopenia. And they are also recommending many anthropometric measures. So one is calf circumference, measurement of calf circumference. So the cutoff points for that is 34 centimeter for men and 33 centimeter for women. Then the extension of SARCF with calf. This SARCF, the cutoff point should be more than 11, so out of maximum 0.20. And SARC-EBM is further extension of SARC-EBM, SARCF, in addition of age and BMI. So age 75 or older, BMI less than 21 kg per meter square, probably they may have sarcopenia. And many sarcopenia risk assessment 7. So which assesses 7 factors, that is age, hospital history, activity level, 3 dietary patterns, and weight loss. 3 dietary patterns, they collect information about regular meal, dairy intake, and protein intake. So maximum score ranges from 0 to 40 and cutoff value is 35. And many sarcopenic risk assessment 5, it omits 2 information on the dietary intake. Other components are similar to MSRA 7, where they do not seek information about the dairy intake and protein intake. So here the maximum score is 60 and cutoff is 45. And short SPSM, short performance sarcopenic measure, so which assesses grip strength and time charge strength test and indirect measure of lean body mass. An easy screening tool, finger circle test. So these were a few of the tools we have to screen sarcopenia. Okay. So what is recommended? So for quick screening, we can either follow the red flag method or the calf circumference using the finger circle method. So what is the red flag method? The red flag method is kind of a checklist that will assist clinician in sensing or identifying the hidden signs and symptoms that probably the individual may have sarcopenia. So either the clinician visualizes weakness or visually observes reduction in the counter muscle mass or slow physical activity, slow gait speed through observation. If they observe these things, or the subject, the client complains of weight loss, muscle weakness, or related signs and symptoms, then further malnutrition, other associated diseases and inflammatory disorders are pre-existing, then possibly the individual may have sarcopenia. So they can be admitted in the probable sarcopenic group and further need to be taken up for the diagnosis. Then we have spoken enough about SARCF, and UB-WACA test is nothing but the finger to thumb circle test. It's a quick screening test to compare the calf circumference, either bigger, just fits the circle, or smaller, right? Or many anthropometry measures like body mass index, calf circumference, mid-upper arm circumference, skin fold thickness, and weight circumference are also recommended. So the traditional approach, red flag screening, can be adapted to have an initial assumption. And the European working group, Asian working group, international working group, most of the international agencies were supporting SARCF questionnaire for screening sarcopenia to stratify the patient under higher risk of probably having a sarcopenia with them. And diagnosis of sarcopenia, this is a screening. So probables, once the individual gets screened under probable sarcopenia category, then diagnosis is planned, which requires confirmation of low strength, low muscle mass, and low physical performance. So these are recommended even though there is no gold standard cluster established till now. Okay. So SARCF questionnaire is recommended, even though it is low sensitivity, but it is highly specific. And there were also recommendations to modify SARCF to make it more sensitive. So the SARCF questionnaire is a tool that is assist clinician in screening individuals who are at risk or having probably sarcopenia. So the components, the acronym is SARCF stands for strength, assistance in walking, raise from a chair, climb stairs, and falls. So it is subjectively asked to the clients, how much difficulty do we have in lifting or carrying 10 pounds regarding strength? And how much difficulty do we have walking across the room? How much difficulty do we have transferring from a chair or bed or raising from a chair? And how much difficulty do we have climbing a flight of 10 stairs? And how many times have we fallen in the past years? So these 5 components were subjectively asked and were scored none, some, and a lot are unable to. So any score more than 4, the individual may be grouped under probable sarcopenic group. Okay. So now to increase the sensitivity of SARCF, many agencies are recommending combining anthropometric measure and SARCF to further improve the sensitivity of the screening. So anthropometric measures, as I mentioned earlier, measurement of body mass index, waist circumference, calf circumference, mid-arm circumference, skin fold thickness. Few of them can be clubbed with, suggestion is to club them with SARCF to increase sensitivity. And mostly they have clubbed SARCF including calf girth and SARCF with EBM, that is age, BMI. And this has improved the diagnostic accuracy or screening accuracy. I would say the screening accuracy of sarcopenia. Okay. So recently the research combination of SARCF, calf and arm circumference, upper arm circumference, was able to identify best screen community dwelling illness in the Polish community. Okay. So the recent international guidelines where they have given guidelines for screening and diagnosis. So the guidelines for screening is older adults age 65 years and older should be screened for sarcopenia annually or after the occurrence of major health events. And screening of sarcopenia can be performed using physical measures like gait speed or with combining that with SARCF questionnaire. And those who are screened positive, that is probable sarcopenia, should be referred for further assessment to confirm the diagnosis of sarcopenia. So age more than 65 years, you can club it with routine checkups or on annual health checkup or during flu vaccination appointments. So it is not to establish a diagnosis at the very early phase, but this will enable us to identify the vulnerable groups or to stratify individuals who are at high risk of having sarcopenia. Simple hints, you think about walking speed of an elderly person, strength, either they sit from a chair or simple gesture of handshaking. If you happen to feel a weakness, either clinician observed or patient complains, then that to trigger that this individual can be screened for the presence of sarcopenia. So diagnosis, as I said, can be established by confirming decline in muscle strength, confirming reduction in muscle mass, then reduced physical performance. So towards muscle strength decline confirmation, hand grip strength, chair strength test were recommended. So a low hand grip strength less than 27.5 kgs for male and less than 18 kgs in females. It's a confirmation that they have reduced strength and reduced repetition in a quick session of time. Chair 10 test, for example, 5 times in 30 seconds, or we do a DEXA, where appendicular lean mass index and chi-square, they have given a cutoff. For men, it is less than 7 kgs per meter square, and women 5.4 to 5.5 kgs per meter square. So these cutoff value confirms that there is a decline in the lean muscle mass. And physical performance, to mention gait speed of less than 0.8 meter second to 1 meter second suggests poor physical performance. So these were recommended batteries to confirm the diagnosis of sarcopenia. So once the individual got grouped under probable sarcopenia, then they can undergo this diagnosis test battery to confirm the presence. So the process of sarcopenia, we screen individuals. If they can be grouped under probable sarcopenia, they need to get diagnosed, and later you can measure the severity depending upon the cutoff score, including muscle strength, muscle mass, and physical performance. So early diagnosis, early intervention can lead to better prognosis. So later intervention, the outcome may not be as expected. So now I want to share a few things what we have done in relation to sarcopenia. So we are, our department is located in a tertiary hospital. So we do many things directly or indirectly with many departments like Department of Orthopedics, Rheumatology, Heart Surgery, Women's Health, Cardiopulmonary Department, many activities we do. And specifically, we did a screening camp in 2003 in World Sarcopenia Day, where the idea is to screen individuals for the presence of probable sarcopenia. So in the single day, this event was conducted on 4th July 2023, where we were able to screen 111 individuals. So out of this 111, 56 individuals were able to group under probable sarcopenia group. So this is the photographs of the camp. And recently, last year, we had a week-long celebration for World Physiotherapy Day with the theme. So where we conducted a sarcopenia screening and counseling camp. So once we have sensed that in 2023, that a lot of proportion of individuals were getting can be grouped under probable sarcopenic group, then we procured this body composition analyzer equipment. So we have this equipment in 2 locations in our campus. So we do it in joint venture with the Department of Cardiopulmonary Physiotherapy. And last year, we started a physical activity promotion clinic. So through this, we are now more objectively evaluating and documenting the lean body mass proportions. So in this camp, nearly we screened 98 individuals, and more than 60% of whom we screened have very low lean body mass. So these were few of the ongoing sarcopenia researches what we do currently. So we are attempting to translate and validate the SARC-QL questionnaire, which can be administered to diagnosed individual. And we are trying to validate the combination of SARC-F with anthropometric measures on Indian population, and many things we do related to sarcopenia. So to conclude, I would say that sarcopenia is a common condition. It do exist. It's high time that the clinicians or whomever is involved in primary care to be aware of its presence and sense that it is one such disease which can go underdiagnosed, and sense why and what for diagnosing sarcopenia at the early phase and implementing appropriate therapy or including nutritional suggestions were important, and what change it could brought up in the quality of life of an individual. We should improve awareness, and simple validated tools like SARC-F questionnaire or with the hand grip strength assessment or any of the anthropometric measurements which we have discussed can be implemented for screening the probable sarcopenia group, and primary care plays a critical role in detection and initiating diagnostic procedures and appropriate care for this special group. So when you see, after listening to my talk, when you see an individual who is aged more than 65 years or has clinical signs and symptoms of what I have listed, then we should think about muscle health. Okay. And stratifying these individuals at risk of having probable sarcopenia is very much possible in the primary care settings. Okay. So thank you, all of you, for your patient listening.
Thank you very much, Dr. Sabai, for your excellent presentation. It was really practical and a lot of great insights. As we can see, a lot of people are sharing that sentiment with the reactions. But please do continue to post questions in the Q&A. I'll now hand to Anthony to introduce our next speaker.
Thank you, Jen. So it's my great pleasure to introduce Associate Professor Ross Clark. So Dr. Clark has a passion for developing physical capacity assessment tools for better assessing clinical impairments and outcomes. With 228 publications, he's both on the current and career Stanford top 2% scientific impact list and was the most read and third most cited researcher globally from 2010 to 2019 in the journal Field Rehabilitation. Today, Ross is going to talk about the frailty and sarcopenia screening device that he has co-invented with colleagues at Singapore General Hospital. Over to you, Ross.
Thank you. Just making sure you can see that screen there. Oh, it's working?
Yes.
Right. Thanks for the invitation to talk, and I think it's great to go after Subia because hopefully some of my stuff will build on his fantastic presentation. So it's really important, as Anthony said, so I need to just put a disclaimer up front. I'm the co-inventor, but not IP owner. The university owns the IP, as does Singapore General Hospital. It's 50-50 of our patent published commercially licensed device screening that's being used for frailty and sarcopenia screening. Therefore, I do have a financial conflict of interest as anyone who's developed a device and it's licenses it off, though. It's not a lot of money is going to come to me no matter how many sold. So we were much more in it for the actual development of the device because we think it's pretty interesting. Now, the other thing I need to talk about is I'm going to hopefully be interesting. I'm going to talk a little bit about the commercialization process of actually licensing the device and what we had to go through to go, is it robust and will a company want to buy this for things like sarcopenia screening? Because it started off as a frailty screening device, and then we pushed into sarcopenia because essentially a lot of people told us that would be fantastic for us to do. So I'm going to start off with a quick quote from Albert Einstein. It's a young picture of him. Everything should be made as simple as possible, but not simpler. And one of the things that we've had issues with as, so my colleague Yong Hao Pure and I, is over the years, things like gait speed assessments, strength assessments, they tend to be too clunky and just not really feasible on a large scale. And we had the challenge of essentially thinking we wanted to be able to essentially, diagnose frailty or sarcopenia in a GP's office in the time it takes to do a blood pressure test, and also as simple or simpler than a blood pressure test. So we wanted to come up with something that a GP could do the test, it would give objective measures, link with electronic medical records, and be very simple for them to do. Because to us, to achieve this as a diagnostic tool, it needed to tick those boxes. Sounds glamorous. What it ended up with was a lot of me burning myself, gluing my fingers together, as I worked with Yong Hao to design the electronics and the software systems that went into the device. Now, I do have some videos here, which will hopefully give you an idea of what it looks like. I'll just quickly explain what it does. So it automates the gait speed and grip strength tests. It's lightweight, easy to use, and we have the patent published now. So because we're using technology essentially from car lasers, we can minimize the error that's involved in gait speed assessment. And we don't need to have someone with a stopwatch or measurements on the ground because it's all fully automated. This video will hopefully give you an idea. So If you think of taking the device out to someone's home, which we want to be able to do, we want community screening, GP screening, that sort of stuff. The top video shows you a gait test set up with a tape measure at 10 times speed. The bottom video shows you our screening device actually doing the full gait speed assessment and grip strength assessment as well at normal speed. So we can knock over the gait speed and grip strength in under 30 seconds quite easily. This video shows the point of view, which hopefully will make it a bit more realistic for you and give you an idea of what it does. So this will be a normal walking speed. You can see there, hopefully my mouse is coming through, it's at 380 in that bottom right corner of the screen. As she comes closer, that's literally just a distance away. So it automates the walking speed. That was a fast one, 1.16 meters per second. So it's in green. A bit slower at 0.85, which is just above that threshold Suvia talked about of 0.8. So it's orange, i.e. at risk. And then if the participant is below the cut point of 0.8 in this example, it flags red. Now, the same thing happens with the strength test. And one of the things, because it's microcontroller based and we can link it to the cloud, is we can have it set up for sex specific, nationality specific, age specific cut points. And one of the other things that we're really excited about is we can also use normative data regardless of the device. So that's one of the key parts for us, is that because it's electronic and we control the calibration, we can compare the grip strength data to Jamar or to any of the other hand grip strength devices out there, because we know based on published data that if you use different types of grip strength devices, you get very different scores. So we can calibrate for it. So you can compare your normative data or the data you collect to whatever device. And we can also compare it to gait speed as well, which Yonghao and I have been doing gait speed assessments for a very long time. And it's very frustrating because even like short physical performance battery, they say 3 meter and 4 meter gait speed tests. But each of those has different accelerations, decelerations, 10 meter walk test, 6 meter walk test. They all give you subtly different results, and we can calibrate it. So if all your data in the clinic, for example, was 4 meter walk test, we can calibrate our gait speed to that based on calibration equations. Now, one of the things we did is we linked this up to bioelectrical impedance scales, because they're a dime a dozen nowadays. They're very cheap, and you can automate that via the API. So it could talk to our device, so we could get gait speed, grip strength, and body mass for frailty, again in under 1 minute. So that ticked our boxes for frailty. So do you walk slowly? Is your grip strength weak? And have you unintentionally lost weight in the last year? So we could follow people up over time. And where we started to get a bit of interest is when people started talking to us about sarcopenia and saying, well, why not use it for sarcopenia? And then we thought, yeah, we'll have a little look. So we've got some tweaks to the bioelectrical impedance algorithms, which unfortunately I can't tell you about today because they're not in the original patent, but they'll be coming up soon. And we can get quite good data, what we've seen for muscle mass. So we thought we were onto something, because with sarcopenia, and everyone here knows, obviously, but like SarcF and those ones, they're good. They're not bad as a simple screening tool, but the sensitivity and specificity of them is quite poor, unfortunately. And when you look at Australian data, each 1% increase in sensitivity and specificity prevents around 12,000 false negatives and around 47,000 false positives, respectively, just a 1% increment change. So it's a huge impact. If you're talking like, 80% sensitivity or 0.8, you're talking around a million Australians getting false positives. And that is a huge problem. So if someone's being diagnosed incorrectly with sarcopenia and they're an older adult, that sounds a little bit scary. So we want to try and minimize that. So we thought it was very straightforward. However, it's not that easy, because what we've sort of come across is that in theory, there's no difference between theory and practice, but in practice, there is the classic Yogi Berra quote. And what I mean by that is, and as it was talked about by Ben in his presentation, and also Subi in his, there's been so many definitions. And I think this title of the journal really summed it up. So sarcopenia, no consensus, no diagnostic criteria, no approved indication. How do we get here from the 2024 article? So when we started looking at the sarcopenia space to try and justify the commercialization of it, we started to look at things like, obviously, the Asian working groups. And this was really interesting when we looked at the different physical performance assessments there. So they had 5-time chair stand tests, 6 meter walk test, short physical performance battery. You could do any of those 3 for physical performance. And then bioelectrical impedance or DEXA. So you have these combinations of different tests. The good thing for us is we tick the boxes, because we've got grip strength, we've got walking speed, and we've got bioelectrical impedance. So that would allow us to bypass all this side of the calf circumference, for example, and get straight to diagnosis in less than a minute, and very simple to do. But then we had things like the Korean working groups definition, where they took a very different approach, and they focused on what they call functional sarcopenia using the short physical performance battery. So I really don't like the short physical performance battery, as do many others I know who are very particular about data collection. There's a lot of reasons why, and it'll take me years to explain, but essentially what was interesting is that was in the Korean, there's this company that sells this device, which was short physical performance battery that's automated. And what was also interesting is one of the authors who was on that original working group, who declared no conflict of interest on it, was on that paper and declared a conflict of interest and actually owned the company, which is the short physical performance battery. So obviously mistakes can be made, and like it might have been an error, and there was a letter that was related to that he did declare that conflict of interest. But these are the sort of things that we had to go through to try and figure out, like, is our device actually good for sarcopenia? And what is interesting is the short physical performance battery in the 2024 Age and Aging paper was shown to have poor criteria and validity for indicating sarcopenia. So that in a way is good for us, obviously. And obviously we may be perceived to have bias that our device is really good, but the short physical performance battery is easy. It's actually really easy to automate with machine learning on phone cameras. Like, we can knock that software up in under a day, and we have done that before. So it's a bit of a shame, actually, because that would make it very, very feasible out there in the real world. And then, as Ben well explained, is the GLIS criteria was the other big one that we had to look at, because the companies and the intellectual property office were asking about it. And as was mentioned, I won't go into too much detail, but muscle mass, muscle strength, and muscle specific strength were all accepted as components of sarcopenia, whereas impaired physical performance was accepted as an outcome rather than a component. So it's not really needed in a diagnostic space, is how we sort of interpreted that, which we thought was quite interesting. So just to put the data there, which is what we found really fascinating as people who are really interested in data and algorithms, the muscle-specific strength, example, muscle strength to muscle size, should be part of the conceptual definition of sarcopenia. It had a mean agreement of 7.5 plus or minus 2.7, an agreement of 80.8%, and was accepted. Whereas physical performance should be part of the conceptual definition of sarcopenia, had almost identical mean and standard deviation, this time 7.5 and 2.6, an agreement of 79.8%. And if you remember from Ben's talk, the cut point was 80% for that, and it was rejected. So that was really fascinating to us, because we looked at 107 participants. You could probably argue that it's a bit of false precision having that extra decimal place, and it maybe should have been rounded to 80, which would have put it on the cut point. So it was really interesting. And the other thing that really stood out, and obviously we can get pretty nerdy on it, but if we're talking means and standard deviations with those numbers, given the bounding from 0 to 10, if you look at it as normal distribution with mean standard deviation, around about 20% of those scores would not exist if you use normal distribution. So that's often how you look at data when you first see it, which told us essentially that most likely there was an asymmetric bimodal distribution, which we thought was interesting, because it implies that there's a lot of people saying that they feel really strongly about something, and then not as many people feeling quite strongly against it. When we ran simulations, that's the only way we could get those means and standard deviation values with those agreement scores. And the other thing I think that was really interesting to us, and the company that wanted to license it when they were talking about it, was that it appears that at most the difference between the accepted and rejected was probably a single person choosing a 6 instead of a 7 on that latter question. Because if you think of 107 people to get 80.8%, that is 86.46 people responding that. Whereas with 107 people to get 79.8% agreement, then you're talking about 85.39% people. Oh, sorry, 85.39 people. So it's one person scoring 6 versus 7. So that made them feel a lot better about pushing forward with a physical performance assessment device measuring gait speed. And this is where, just taking that step back to our original challenge, like, can we compete with blood pressure monitoring in terms of ease of use? So again, in theory, there is no difference between theory and practice, but in practice there is. When we looked at the muscle-specific force, the definition of it, from the GLIS group. It's defined as strength standardized to muscle size. For example, leg extension 1 RM standardized to quadricep volume or computed tomography cross-sectional area, or leg soft tissue lean mass. That's the definition from the article. Now, as from a biomechanics background, like we know with simulation of muscle force, it's actually extremely difficult to do. So if you were doing, say, 1 RM leg extension, you'd have to factor in moment arms, elastic energy of the tendons involved. So to actually quantify muscle force, and given sarcopenia is so focused on the muscle, would be quite difficult to do. Even a simple isometric test of a muscle would still be difficult to quantify that. So theoretically, that would be interesting, be quite a challenge, but practically, like, how could we get that to work in the real world? Like, how could a GP do this in less than a minute? So we kind of took a step back and go, where does that leave us? It does leave us hitting these EWG SOP2 guidelines and the original Asian Working Group guidelines of we have gait speed, so we have strength. So are you weak? Are you walking slowly? And do you have low muscle mass, which we can get from our tweaked bioelectrical impedance? So grip strength, yes. Gait speed, yes. These answer those questions. But then obviously there's other questions too, which we got asked a lot about. So why not short physical performance battery? Again, I've sort of talked about that before. Sit to stand is another common one. Again, that would be fantastic to if we could use that, because it's so easy to automate with machine learning on phone cameras. But unfortunately, we've got chair heights, we've got different foot positions or knee joint angles, cushioning in the chair. All those things have a huge impact on the actual scoring. Plus, not to mention trying to like standardize hand placement, things like that. Ultrasound muscle quality, as someone who's done thousands of ultrasounds of muscles to look at things like that, it sounds good and reliability is not too bad. But again, thinking of a GP, like how are they actually going to implement that in practice in less than a minute? And then even something as simple as calf circumference, which is quite attractive. Like how does the GP do it? Like, do they have to get down on like their knee to put it around the thickest part of the calf? Like how are they actually doing that in reality? And what if the person's wearing jeans or as a Muslim lady who won't expose the leg? It's very quite tricky. So we wanted to make it as broad and as quick as possible. And if something was harder to do, it must be much better. So it had to really prove itself, which we've yet to see so far. So now where we're at, well, our belief is that whatever device that you or we choose, it must link with electronic medical records. So it's got to go straight in. It can't be writing things on pieces of paper, can't be putting it into an app, which then gets transferred later on. So that's one of the big things, and we're fortunate to get to work with Singapore General Hospital, which is one of the larger hospitals in the world. And it must be actionable. And that's where we're thinking, things like chatbots. It's easy to link up chatbots with the software, can feed off the data. Interventions, one of the good things about sarcopenia and frailty is there might be exercise and nutritional interventions, which are actually functional. But I think, and it's come out of the talks today, one of the most important things that it just has to be practical. It needs to be something we can do on a mass scale, which is sensitive and specific and is an accurate measure of sarcopenia. Thank you.
Thank you very much, Ross. That was an excellent presentation, really innovative work and inspiring. I'll now share my screen to bring to Chris Salat for the closing remarks.
My voice is audible, right? Can I proceed?
Yes, yes, yes.
As we conclude this enlightening webinar, it's evident that sarcopenia is no longer a condition confined to academic discussions, but a pressing public health concern demanding our immediate action. Today's discussions, from defining sarcopenia to exploring cutting-edge technologies, have highlighted the urgency of moving from recognition to action. About the definition of sarcopenia, excellent research has been carried out by Dr. Ben Kirk and his team from Global Leadership Initiative in Sarcopenia, and the Delphi surveys which are underway will soon help us reach a global conceptual definition which would help us establish primary care pathways integrating sarcopenia within the healthcare system. And about the assessment and screening by Dr. Subbiah, He took us through the challenges and barriers in diagnosing sarcopenia at the primary health centers and to think muscle health in every older adult. About the technologies by Professor Ross Clark. Yes, in theory, there's no difference between theory and practice, but in practice, there is. That's right. By bypassing numerous tests, lack of standardization is accepted, but there are practical issues which need to be considered. On our work about this webinar, this began 2 years back when we came across this website and which sparked a series of events leading to this joint webinar today. At this point, I would like to mention Dr. Jennifer and Dr. Anthony Villani, President of Australia and New Zealand Society for Sarcopenia and Frailty Research, whose unwavering engagement have been instrumental in making this event a great success. My heartfelt thanks to Professor Anthony Leo, Principal Sri Ramachandra Faculty of Physiotherapy, for supporting us and encouraging us throughout our activities, which led us through this collaborative event. By embracing these novel technologies, we can shift from reactive to proactive stance, identifying at-risk individuals early and tailoring interventions that will preserve muscle health and overall the quality of life. My special thanks to all our distinguished speakers and attendees for making this event a resounding success. As we conclude this insightful webinar on World Sarcopenia Day today, let us carry forward the key message that muscle health is not just a clinical concern, it is a cornerstone of functional independence, longevity, and quality of life, nurturing a collaborative and action-driven approach in the fight against sarcopenia. We can build a future where aging with strength is not just a hope, but a standard. Thank you once again.
Thank you very much, Chrysolite. And I think you've given such an excellent closing remarks. And I think we also need to recognise your exceptional contributions to the success of the event. So thank you very much. We had a number of questions in the Q&A in the chat there. And thank you very much to our speakers for being so proactive in providing such comprehensive and really thoughtful answers. There have been excellent questions raised. We do have some time remaining. We have about 10 minutes or so. So if there are any further questions, you're most welcome to raise your hand and you can come off mute, or you can continue to post in there, which I can see is happening now. So I will bring over to here. So Dr. Subbiah, we have a question for you. And the question is, for individuals at risk or already diagnosed, what are the most effective type of exercise intervention and what are the recommended intensity and frequency guidelines? Would you be happy to answer that one for us, Dr. Subbiah?
Yes, Dr. Jennifer, I got your question. So to answer to the question, so they are recommending progressive resisted exercises and more of aerobic exercises, keeping in mind the special group what we are handling. Those are more prone to face endurance issues, fatigue issues. So keeping them in mind, a planned, individualized, planned progressive assisted exercise and aerobic exercises is what is the recommendation.
Thank you very much for answering that one for us. Are there any further questions? I'll just check. I think I'm also getting excellent. So while people are thinking of more questions, I will Crystalite has very generously put together a feedback survey for us. So if you could please complete that feedback survey, we really appreciate your input. This event has been very well attended. We've seen over 300 people attending, which is fabulous, and over 500 registrations, and no doubt there'll be more to come as people engage with the recording. So please do take a moment. It should be very quick, but it will be very rich data for us. Are there any further questions or discussion points that people would like to raise?
I should probably outline something, because I think Ross very nicely had a good interpretation of the GLIS survey and how impaired physical performance around gate speed was rejected. But actually, so we specified on that, Ross, pre-specified criteria, and we only had 2 rounds for the Delphi. And we had our pre-specified cutoff points. And on the topic of gate speed, that was rejected on the first round it was, what did it score? Yeah, it was 0.6 away. And then when we reintroduced it in the second round, it was, I think it was 79.8, so 0.2 away. But statements have to be above 80%, not just on 80%. So it was a few, to our surprise, that it got rejected. It was a bit away. But I appreciate what you were saying there about the distribution and how that could have flipped basically by 1 or 2 people, I think would be fair to say.
No, I understand.
Yeah, so on a Delphi survey like this, there was other things as well, like muscle power. It's not a one person's opinion. It's a Delphi survey that you do, and it was objected, and muscle power was rejected. But for me, I think muscle power maybe has stronger influence or predictive capacity beyond strength or mass. So yeah, it's a democracy in that sense. But I think it was a good point you raised, though, that it was very close. And I should mention as well that the gate speed will still be as a recommended outcome. It was accepted as that, as impaired physical performance. So I think it does have relevance. It still has relevance in the field.
Yeah, I was curious on that, Ben, why you point to that, because I might have interpreted incorrectly, but in round 1, muscle specific strength was rejected because it got 72.3%, and then round 2 was 80.8. And I think what I was probably meant to say, I probably didn't word it very well, but the errors are the estimate of the mean. So like having a mean so close to 80, like it's not really 80, it's somewhere between like 70 and 90, for example. So normally with statistical analysis, you would go, obviously it's not above 80 with a 95% confidence interval. So that's why it was interesting with the Delphi, like that one person could shift the recommended diagnosis away. So if there was one person entered 6 instead of 7 for muscle specific strength, then it wouldn't be in the GLIS criteria, which we thought was quite fascinating.
Yeah, I mean, they were I just have to look at there was a number of surveys. I'm trying to look back now on the ones that were reintroduced, because there was a question on severity as well that was rejected, and it was in the moderate criteria, and then we reintroduced it. But yeah, overall, that was the way it went by the procedures. It seems to be, it was a few people could have swung some certain statements, but as I said again, we went with an evidence-based approach that to try to define it, But of course, there's probably you got statisticians on board, and they would have found improved ways to do this for sure.
Yeah, great. Thank you.
So, and Professor Ross Clark, so I would like to share your insight regarding an issue. So just a moment before this webinar, I had a discussion with one of our orthopedic surgeon, Dr. Mohammed Samir. So he was asking about sarcopenia is more commonly prevalent in individuals, those who sustain hip fractures. So to confirm the presence of decline in muscle mass post-fracture individuals, other than DEXA and BAA, whether any standardized or recommended gold standard tool available? This is what he raised this issue to me. So could you provide your insights in this?
Yeah, and look, Ben might have some really good insights. I know Anthony would too, but the D3 creatine seems to be very interesting, and it's something we looked into when we've been validating our a new IP. But essentially, it seems really hard to actually do in reality, even for research purposes. It would be nice to be able to do, but essentially, you have to take it the night before, then urinate it, collect it, have it assessed. I don't, and again, there's been articles published just this last year talking about the difficulties of assessing lean muscle mass. Ultrasound's a reasonably good way, I would think. But if they have access to MRIs, obviously that's a good way too. But I honestly, and Anthony would have more idea than me, but I don't know if there's a perfect gold standard, which is something we struggle with, because when we try and compare our new device in terms of biological impedance tweaks to a gold standard, and there's not one, it's really hard.
Then
I could
probably
probably
I think we have to work in developing one.
Yeah, definitely.
I can probably elaborate on that. So the working group on the muscle mass will come to a definitive decision, at least for now, on what the recommendations are, and the considerations are going to be not only how accurate that measure is, so things like MRI, like what Ross mentioned, stable isotope using creatine dilution have shown to be very predictive against MRI and for predicting poor outcomes, but feasibility and accessibility across all different regions in the world to get a definition integrated by WHO. The methods of screening and diagnosis should be considered in all different places, regions. So these are important aspects that are all going to be explored through Adelphi in the muscle mass working group. And there will be things like DEXA, BIA, so less accurate measures, but they are a little bit more accessible to countries. Although even I can give you a caveat of that, people think that DEXA is accessible, but in South Africa they have 2 or 3 DEXA machines only, so there presents a problem in itself. But at the end of GLIS, there will be a set specific recommendations on these questions that you're asking for. And if they're not accessible, there'll be a screening tool recommended, and that will be for globally.
Yes, thanks, Dr. Ben.
Well, I think that brings us to an excellent conclusion of this fantastic joint webinar collaboration, thinking about World Sarcopenia Day. In preparation for the webinar today, I did my strength and resistance training this morning, knowing that there would be a lot of discussion about that, and feel really good that I've done that now. But come Friday, please do. We saw some great initiatives like by Dr. Sabayad. I love the idea of the camp and the screening. So please, and so many practical tips, so how we can really promote, screen, diagnose, and provide exercise and nutrition counselling for people at risk of or who are developing sarcopenia. So thanks again, everyone, and I'll now conclude the recording, and we hope to see you again soon.
Thanks, everybody.
Thank you.
Thank you
Thanks
all.
so much,
See you.
everyone.
Thank you.
Bye-bye.
Thank you.